Good evening, all the aspirants present here. Good evening, sir. So, the topic for today is Station 1. It is respiratory. And the speaker that we have here is Dr. Chinmay Maity, sir. He is a senior consultant and general and geriatric medicine. So, sir, you can unmute your mic and we'll be starting. You can start. You can take over. Thank you. You can start.
Now, can you hear me?
Yes, sir. Aspirants,
Okay.
this is going to be an interactive session as it is MRCP PACES. So all the aspirants are required to kindly unmute their mic whenever it's required. Thank you, sir.
Okay, thank you. So, good evening, everyone. Hello.
Good evening,
Hello.
sir. Good evening, sir.
Good evening, sir.
Yeah, okay. Welcome you all to today's session on respiratory examination. uh, so, I'm going to discuss today. It's a huge thing. In one session, it's not possible to complete body, but I will stress mainly on the basic anatomy, physiology, and the way, the process of examining how to do it, and direct case examinations will be at the end. But I think that probably hands-on will be better. But anyway, whenever you want to ask a question, actually you can pause me and call me and ask me the question. Um, so actually, we know our today's topic is respiratory examination. But before any systemic examination, we must have a general examination at a glance, because if it is a very sort of short case, then it will be very brief. Then it is a sort of semi-long case type things, then it will be little more in details. So the stations and where which cases are done. So I'm briefly discussing on what are the general things we have to have a look before going into the proper systemic examination. Um, so general examination, there should be a very quick visual survey of the patient. And as you know, this is PACES, that means the practical examination session. So theory will be there a little bit, but not much. But so visual survey, that means when you are actually confronting the patient for the first time, how you see the patient, the appearance and attitude of the patient, that's very important at your first sight. Whether the patient is calm and quiet, or whether the patient is unkempt, restless, or patient is cachectic or obese, sort of thing. The very first look. So most of the time, it may be the patient is comfortable and alert, that sort of thing. Then anemia, cyanosis, jaundice, clouding, edema, maybe neck veins, lymph nodes, and the pulse, blood pressure, respiration, saturation, and maybe in blood glucose level. So this is a very basic general thing to be completed. Most of them in the real life situation, you will see the pulse, blood pressure, respiration, saturation, and CBG done by the nurses. So when you are seeing a patient in the A&E, or maybe in the outdoor, many of these things are done by the nurse assistant. But when you are seeing the patient on your own, this must be included in the general examination. Now we are coming to the respiratory examination, the basic anatomy, then basic physiology, the cardinal symptoms and signs, then a bit of surface marking of the lung, and then we'll go into the examination proper. So we must have a very good understanding of the basic anatomy and physiology of our respiratory system, which we are going to discuss today. Can you hear me?
Yes, sir.
Okay. Now we are coming into the basic anatomy of the respiratory system. We have an upper respiratory system, that is the nose, nasal septum, paranasal sinuses, nasopharynx up to the end of the larynx. And then lower respiratory tract starts from the beginning of the trachea, then two main bronchus, then bronchioles up to the alveoli. You all know that the when the bronchuses are branching, so there are the trachea is the zero generation, the main bronchus is the first generation of tracheobronchial tree. Then comes the segmental bronchus, that's the third generation, second generation. That's how it goes on, and up to the terminal bronchiole, which is about 16th generation, and this terminal bronchiole is the last one of the conducting zone. That means it has got a cartilage in the wall. After that, it comes the respiratory bronchiole, which does not have any cartilage. And so from respiratory bronchiole, which is about 4 to 5 generations of respiratory bronchioles are there, and then alveolar duct, and then alveoli, which is called the terminal or last generation, that is 23rd generation. So trachea is the zero generation, then main bronchus, two main bronchus is the first generation, and alveoli are the 23rd generation. It as if like a tree, the stem is zero generation, first branch is your first generation, and then the leaves at the end, leaves are the 23rd generation. So basically conducting zone up to terminal bronchiole, which is the 16th generation, and then from 17th to 23rd generation where the actual gas exchange takes place. So that's the respiratory zone. Then we must know the segmental bronchi. In the right side and the left side, right side there are 10, and the left side there are 9 segmental bronchi. And this is very important to know the lung segments. So right upper lobe bronchus, that divides into 3 apical, anterior and posterior segment. Then the right middle lobe bronchus, it is divided into lateral and medial segments. Then the right lower lobe bronchus, it's apical, anterior, posterior, lateral, and medial segments. This medial one is missing on the left side. So apical, anterior, posterior, lateral in the left side, lower lobe, and the left upper lobe bronchus divides into two, the upper lobe and lingular lobe. So lingular one is superior and inferior, and upper lobe is similar to right upper lobe, apical, anterior and posterior segment. So this you must know that there are these 10 in the right and 9 in the left lung segments. Then the basic anatomy continues. After the respiratory tract, then comes the bony chest cage. The bony chest cage it consists of 12 thoracic vertebrae in the back, then 12 pair of ribs and costal cartilages, and the sternum in the front. Then comes the respiratory muscles. So respiratory muscles, the normal respiratory muscles are external and internal intercostal muscles, which raises the ribs on both sides like a bucket handle fashion, and the diaphragm in the below, which moves like a piston up and down. Then the accessory muscles are allinajai, sternocleidomastoids, pectoralis, serratus anterior, trapezium, and scalene. So these are the muscles we may see working when the patient is in respiratory distress. Otherwise, normally they do not work. Then the respiratory nerves, very important. The phrenic nerve, which is formed from C3 to C5 segment, which supply the diaphragm. So if there is phrenic nerve injury, there may be diaphragmatic palsy, and which can lead to shortness of breath. Then the intercostal nerves are coming from the ventral rami of T1 to T11 segments, which supply the intercostal muscles, the motor part, and then the sensory part supplies the overlying skin as well as the underlying parietal pleura. We also have other three nerves which are responsible for control of airway reflexes like cough reflexes. This is the vagus nerve, the glossopharyngeal nerve, and trigeminal nerve. Now comes the higher control. The higher control, that is the respiratory center, is situated mainly in medulla and partly in the pons, which is responsible for the autonomic control of breathing. It's like the cardiac pacemaker sinus node. We actually, our respiratory drive comes from medulla. And this is the autonomic part of the respiratory system. But as you know that in the respiratory system we have some voluntary control, because we can hold the breath, we can take deep breaths, we can hyperventilate, we can stop ventilation for a while. So this is the control which is the voluntary control. This voluntary control comes from cerebral cortex. So this is the basic anatomy we discussed: the respiratory tract, the bony chest cage, the respiratory muscles, the respiratory nerves, and the higher control. So a problem anywhere in this system can lead to breathing problem. Can you hear me?
Yes, sir.
Okay. Yeah. And now we are coming to the basic physiology of the respiratory system. The Our lungs, they have two distinct functions. The most important primary function is the gas exchange between air and blood. The gas exchange, we need oxygen for our internal metabolism in the mitochondria. So that's the most important thing. Otherwise, no energy or no ATP will be generated in our body. So we need oxygen, and the byproduct is carbon dioxide that has to be removed from the system. So the lung plays the vital role of this gas exchange process. That's one thing. And the second issue is, because of the metabolism inside the body, we generate lots of hydrogen ions and free radicals, etc. So that actually, this hydrogen ions makes the system acidic. So the acid base balance, for maintenance of acid base balance, lungs play a very vital role in association with the kidneys. So this is the second part. Coming to the primary function, the gas exchange, that happens through the process called ventilation. The ventilation, I am just discussing very briefly. The What does it mean? So the normal respiratory rate in a young healthy adult is somewhere between 15 to 20 per minute. And the tidal volume is the volume of air inspired or expired during normal breathing. Just suppose I am talking to you now, or you are listening to the lecture, but so that's the normal tidal volume breathing. How much air? Can you tell me how much air enters during normal breathing?
5 liters.
Hello, what's the normal tidal volume?
500 ml.
Hello, can you hear me?
Yes, sir. 500 ml normal tidal volume.
Yeah, so 500 ml normal tidal volume is for an adult male, but it's for adult female, it is about around 400 ml. Okay,
Okay. Okay.
so 500 and 400. Then the vital capacity, the volume of air expelled by maximum voluntary expiration after a maximum inspiration, that is called vital capacity. The other figures we use, forced vital capacity or so on. In functional residual volume, the volume of air remaining in the lung after normal expiration, that the functional residual volume. However, when the only is an important parameter here. This is the time taken to deliver the vital capacity. May deep breath, when we forcefully exhale as quick as possible, then the time is measured. The normally the forced expiratory time to exhale the whole vital capacity is normally between 3 to 4 seconds, and this FET or forced expiratory time, if it is beyond 6 seconds, it indicates the airway obstruction. And this is a test which can be easily done on the bedside. As we do the FEV1 by FBC ratio in the lab, which is less than 70%, indicates obstruction. So this is the ventilation. So if someone has got a respiratory rate of 20 per minute and the tidal volume is 500 ml, then the total amount of air entering the lung or exiting the lung is about 10 liters. So 10 liters of air is entering. So it should be somewhere between 6 to 10 liters. So 10 liters. And so that 10 liter, the oxygen inside that is exchanged with the blood inside the pulmonary circulation. Now next comes the gas transfer. Gas transfer, the exchange of oxygen and carbon dioxide between the alveolar air and the capillary blood. This depends on the following factors. The first thing is the distribution of air and blood flow. Um, so that is called the ventilation perfusion matching or combination. So if there is enough ventilation, but in the opposite is also true. There is lots of perfusion, but no ventilation. Then that will be also sort of as a dead space. That will no gas exchange will take place. So for a sort of good gas transfer, we need a ventilation perfusion matching. Then the second is diffusion of gases. So before going into that, so this oh no, I think I'll discuss that in pulmonary blood flow. Okay, okay. So diffusion of gases depends on the surface area of the respiratory membrane. So the total surface area of the respiratory membrane, that is the alveolar surface in contact with the capillary surface, is about 70 square meter. So about 70 square meter if it is spread wide open. And the amount of lung perfusion at any particular point, at any point is around 100 ml of blood. So 100 ml of blood is spread across a 70 square meter area, and then through the respiratory membrane, the gas exchange is going on. So the third point is so amount of blood and surface area, and third is the thickness of the respiratory membrane, which is called the blood gas barrier. So that is formed by the alveolar wall, the capillary wall, and the interstitial tissue in between, so that is the thickness of the respiratory membrane. If there is any disease of the of this area, that means like pulmonary fibrosis, so this respiratory membrane becomes very thick and the gas exchange may be jeopardized. And the fourth point is the solubility of the gas. The solubility of the carbon dioxide is many times more than the oxygen. So that's why the oxygen is very easily transferred, but it is not that easy for the oxygen. So now comes the pulmonary blood flow. The pulmonary blood flow is primarily determined by the gravity in the upright position. In the upright position, the least blood flow is in the apex of the lung, and the maximum blood flow is in the bases. If you lie down, then there is much more sort of symmetry, the base and the apex. However, due to the homeostatic mechanism inbuilt in an otherwise normal lung, there is ventilation perfusion matching in most of the places. But if there is significant pulmonary disease, then that may be seriously jeopardized. So pulmonary blood flow, the blood gas transport, the how, then okay, then oxygen entered into the blood from the alveoli, then how it is transported in the circulation. Oxygen is transported in two ways. The majority of it is binding to the hemoglobin, which forms the oxyhemoglobin, and then it goes to the tissue, and then oxyhemoglobin is deoxygenated, so it releases the oxygen which goes to the tissue. And the second part is small amount is dissolved directly into the plasma, which gives you the plasma oxygen, the pressure, SpO2. Then carbon dioxide is transported in three ways. The one is the binding to the hemoglobin like the oxygen, and it makes what is called carbamino compound or carbamino hemoglobin. Then the second is a small amount is dissolved into the plasma, but the majority of carbon dioxide is transported as bicarbonate ions. So because carbon dioxide, when combines with water, it makes the carbonic acid, and which divides into hydrogen ion and bicarbonate ions. So that's the majority of carbon dioxide is transported as bicarbonate ions. And just a second. Uh, the factors affecting the gas transfer is actually, one is the temperature, the pH, and the partial pressure of the gas. So partial pressure of the gas, then the pH and temperature. Next, coming to the cardinal symptoms and signs of this is the very basics, as I think you all know, but I'm just recapitulating it. That cardinal symptoms, as you all know, the respiratory shortness of breath, dyspnea or breathlessness. That's the one thing, and then maybe noisy breathing or wheeze. Third, maybe cough, which may be dry cough, or with sputum, that is productive cough. Then sputum or flame, maybe blood in the sputum, that is hemoptysis, and maybe chest pain or discomfort. So these are the common cardinal symptoms of the respiratory system. And what are the signs? The patient may be breathless, dyspneic or orthopneic. So that's the breathless part. Maybe cyanozed. Then they may have abnormal shape of the chest cage, or there may be scars. Then the abnormal chest wall movement, there may be limitation of movement there in any particular part. Then the localized dullness, then vesicular sound, which is usually the normal one, or bronchial breathing. This maybe these may be normal in some part of the lung, but bronchial breathing may be abnormal in other places. Then the abnormal or adventitious sounds like ronchi, wheeze, and crepitations, that is wet sounds. So these are the cardinal signs of the respiratory system. Now we are coming to the surface marking of the lung. When we are clinically examining the patient, this is very important. So the first coming the upper border of the lung, that is the apex. Where is the apex? The upper border or apex is 1 inch above the medial 1/3 of the clavicle. So just 1 inch above the clavicle, medial 1/3 of the clavicle. So that there lies the upper part of the upper surface marking of apex. Then the lower part, lower border, so it's on the 6th rib on the mid-clavicular line, 8th rib on the mid-axillary line, and the 10th rib on the scapular line. That's the lower border of the lung. So actually the lung is covered with pleura. So when we are coming to the lower limit of pleura, it's just 2 spaces below. So the lower border of the pleura is 8th space on the mid-clavicular line, 10th space in the mid-axillary line, and the 12th space in the scapular line. So there's the lower border of the lung and lower border of the pleura, 2 space below. Then where is the oblique fissure? The oblique fissure starts from the second dorsal spine, so second T2 or D2 dorsal spine posteriorly, then it goes down and laterally, and from the side it comes medially to join the sixth costochondral junction anteriorly. So that's the oblique. So second dorsal spine on the back and sixth costochondral junction in the front. And so which, and then transverse fissure, it starts from the fourth costochondral junction and goes laterally up to the mid axillary line where it joins the oblique fissure. So from fourth costochondral junction going to the mid axillary line laterally, transversely, and joins the oblique fissure. Then comes the hilum of the lung. So where lies the hilum of the lung? No, at the level of fourth, fifth, and sixth dorsal spine. So fourth, fifth, and sixth dorsal spine between the midline and the medial border of the scapula on the back side. So that's the surface marking of hilum. Then you all know the sternal angle or the angle of Lewis. This is the junction of the manubrium sterni with the body of the sternum, and it's an important anatomical landmark. Important anatomical landmark. Here, the second costal cartilage joins laterally. Then the trachea divides into two main bronchus at this level, and it corresponds to the disc between fourth and fifth dorsal vertebrae posteriorly. The three landmarks corresponds to this angle of Lewis. Now we are coming to the respiratory examination proper. Are you all okay?
Yes, sir.
Hello. Okay. So actually I can't see you. So can you tell me your name, please?
Myself, Dr. Aman. I'm from Aligarh.
You are Dr. Aman. Okay. Anybody else there? Hello.
Dr. Chinmay, sir. I'm from
Hello.
Hyderabad.
You are from?
Hyderabad, sir.
Hello.
Hyderabad.
You are from Hyderabad. Okay.
Yes.
Welcome. So can you the so long you can see the screen and you can hear me well?
Yes, sir.
Okay. Thank you. Now coming to the inspection, because you all completed the MBBS or you have done something else as well already. So these are the things actually you have gone through a few times in your life already. But in this MRCP exam, actually, you are going to do the same thing again. But you have to look more professional and to show the examiner that you have done it 100 times. It's like it's like bread and butter. So that sort of thing, it should be in a professional way. So that's how we have to practice meticulously. That's the thing we have to do. You all know these things. So inspection starts with a visual survey, as I mentioned in my probably the first slide, that any systemic examination should start with a visual survey for the general appearance, and here it also same thing with the respiratory inspection. When you are seeing a patient and you see obviously the patient is very short of breath and he cannot lie down sitting up, and he is tachypneic, cyanosis, that sort of thing, what you can apparently see on visual survey. So that should be the first thing to see. That or you are seeing going to examine a patient who has got a chest drain hanging from the side. So that's the visual survey. You can see, oh, has got a drain in situ. So those sort of things actually, or the patient is very very obese and and he looks like he's suffering from obstructive sleep apnea type things, and gross core pulmonal type features there. So these are the visual survey you have to see. or maybe the patient very cachexic age, or sort of maybe advanced lung cancer or something, or maybe tuberculosis, is lost a lot of weight. So these are the visual survey. The general appearance should be looked the first thing. And when you are starting examining, obviously you must introduce professionally to the patient, uh, must ask the name of the patient and take the permission that whether you can examine him or her. So that's the very important thing. And when you are examining the chest, obviously you have to open the chest to for inspection. If it is a female patient or male or female, whatever, you have to take permission from them, and you have to be very courteous. That and in case of female patient, you need a chaperone. So that's the you must not forget about that. Then second thing comes the inspection of the chest cage. It should be, the patient should lie or sit without any sort of bending or anything. It should be symmetrical, and you must examine from front, from back, and from the lateral aspect, uh, um, to see the size, shape, and symmetry of the chest wall, any localized depression, bulging, and then obviously look for the respiratory movements, whether there is any obvious restriction anywhere, any scars, any sinuses, any drain, etc. You must look for those things. And then respiration, definitely you will check the respiratory rate, whether the rhythm, which is normal, like your heart sinus rhythm. We don't say that in breathing, but it's a regular rate of around whatever 15 to 20, as I said, normal. It will be somewhere there, or if it is maybe tachypnic. Type of movement of the chest wall, that is important, whether symmetrically moving on both sides, or whether the patient is just the chest wall is moving up and down. There is no lateral, so transverse movement that can happen in barrel chest. Intercostal suction may be there, or the activity of the accessory muscles of respiration. The accessory muscles of respiration may be working, as you told initially. The alanasi, sternocleidomastoid, pectoralis, etc., trapezium, they may be working to help the breathless patient. Then look for cyanosis, and that should be the central cyanosis should be looked for in the lips and the in the oral mucosa, and obviously in look for that in the hands and nails, etc. The clubbing, obviously, in the hand nails, and you must know details about these things, the clubbing, grades of clubbing, causes of clubbing, etc. Cyanosis as well. Then we look for any visible chest wall veins, as it happens, as you know, the superior vena cava obstruction or superior vena cava syndrome is a one case which is sometimes given in the examination, because it's not an acute case. It's usually relatively stable cases. So in the exams, if they have a case, they usually will get a case superior vena cava syndrome. There's obstruction of the superior vena cava, and you will find the engorged, dilated blue veins in the necks, which are fixed, and then scars, any sinuses, any drainage, as you mentioned. Then look for any visible cardiac pulsation, which may be the parasternal pulsation if there is a right ventricular hypertrophy, as happens in pulmonary hypertension or core pulmonal situation. And then look for and palpate for the apex beat. The apex beat, the usually normally in the fifth intercostal space, as you know, about half an inch inside the mid clavicular line, but this may be displaced if there is suppose massive pleural effusion in one side, or pneumothorax in one side, or if there is significant fibrosis in one side, which is pulling everything to that side. So these are the depending upon the underlying pathology, the apex bit may be shifted. Then comes the breathing pattern, as you mentioned, rhythm and pattern. So there are few patterns we know: the abnormal breathing patterns, the chain stroke breathing, the stertorous breathing, the Kussmaul's breathing or hair hunger, asthmatic or wheezy breathing. The chain strokes breathing, as you know, here what happens: the patient has an episode of apnea, then means stops breathing, then the breathing starts slowly, gradually, the rate and depth usually increases, then it decreases to another apnea. It happens like that. Usually, it is seen in case of raised intracranial tension from intracranial hemorrhage or cerebral edema, or maybe in any of the severe organ failure state, severe pulmonary failure, severe cardiac failure, severe renal failure, severe hepatic failure. All these can lead to chain Stokes breathing. And stertorous breathing. This is also seen in cerebral hemorrhage and some other serious conditions. Kussmaul's breathing or air hunger, that means here the very deep breathing like air hunger. It happens in metabolic acidosis usually, and like diabetic ketoacidosis is a classical example for Kussmaul's breathing. Then asthmatic sticks may have the airway obstruction leading to wheezes, and so the noisy breathing. That's another thing. So these are the abnormal breathing. So chain strokes, stertorous, Kussmaul's breathing, asthmatic or wheezy breathing. So these are the things in inspection we may find. So visual survey, inspection of the chest cage from front and back and side. From the side, we look for any kyphosis from back and front, or any scoliosis, those sort of things also. And then respiration rate, rhythm, type of movement, the intercostal suction, accessory muscle of respiration activity, cyanosis, clubbing, visible chest wall abnormality like prominent veins, scars and sinuses, visible cardiac pulsation, apex beats, and then any particular type of abnormal sort of breathing. So this is the inspection part gone. Now comes the palpation. So what are we going to palpate in case of the respiratory examination? At first, we should examine any obvious area of abnormality. If we can clearly see an area of swelling in the chest wall, or if the patient is complaining of pain in a particular area of the chest, then we must carefully examine that area, so that in subsequent examination we do not hurt the patient causing too much pain. So that examine that area first. Then obviously we look for movement of the chest wall. It should be done from the front and the back, and look for any asymmetry. So it should start from it should actually the movement of the chest wall, it should start from the apex to the base. So in the front, we usually put your both hands, the palms, both palms. A patient should lie at a 45-degree angle, the chest exposed, and then put both the palm on the the clavicle, and both the thumb of the hand should touch side by side, and then just slightly put the hand there and ask the patient to take breath. So both hands will go up and down, up and down. If one side is less moving, then that side the thumb will lag behind, other side will go up. So that's how we measure that on any side there is any apical area movement, which happens like this, up down movements. And then comes the sub infras clavicular area, and then intramammary area. So those are the done with putting the hands laterally, and both thumb at the center of the sternum, with a small skin fold in between, so that once the patient takes deep breath, that is there is inspiration, the chest wall expansion, the hands goes laterally, and there is a gap between the two tip of the thumbs. And if there is any restriction on one side, that's really it will move less. So that's actually the same thing should be done on the back as well. Um, uh, Back means in the suprascapular, then interscapular, then infrascapular area. Then the third thing to be done is to measure the chest expansion with a tape. Is usually inframammary area. We do check it, and or around the, in male is around the nipple or just below the nipple. So normally there should be at least 2 inches or at least 5 centimeter expansion from expiration to inspiration. If it is less than that, then there is some problem with the chest cage or the lung itself, like your pulmonary fibrosis, or patient may have ankylosing spondylitis and so on. Then a fourth part comes is to palpate the trachea, position of the trachea. It's actually when the patient is lying at 45 degree symmetrically, you put the middle finger of your right hand at the suprasternal notch, and if the trachea is at the center, you will feel it, you will touch the trachea, and then you put your index finger on the right hand side to see the gap between the sternocleidomastoid and the trachea on that side, and put the ring finger on the other side to see the gap on the other side. It's usually center or slightly, trachea normally remains slightly to the right, but so that's the position. But if there is any particular pathology, suppose massive effusion or pneumothorax or fibrosis, so then it will be shifted to the opposite side or the same side if it is the fibrosis. Then palpate the apex beat. You will know how to do it, and the normal position, as you mentioned, is the fifth intercostal space in case of adult, fourth intercostal space in case of children, about 1/2 centimeter, half inch inside the mid clavicular line. Then comes for the vocal parameters. What is vocal parameters? Now, when there is sound produced in the vocal cord, that may be sort of transmitted through the respiratory tract, through the alveoli, into the chest wall, and usually we ask the patient to say 99, 99, like a high pitched sound, 99, or tin, 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 or means 333, basically tin in Bengali, um, or 99, 99, and with the palm, you the infraclavicular, mammary and inframammary area, laterally axilla, infraaxillary area, and back suprascapular, interscapular, and infrascapular area. So look for that. These vocal parameters may be affected, and you know, if there is again the problem, if there is consolidation with the patent bronchus, that it may be exaggerated, and otherwise it may be reduced in pleural effusion or pneumothorax and so on. Then bronchial parameters, if there is obstruction in the tracheobronchial tree, we hear ronchi, or the dry abnormal sounds. So that may be, if it is sort of severe enough, then we may palpate that with our palm on the chest wall. Then comes the friction parameters. If you are thinking of underlying pleurisy, that when we pleural rub, which you will hear in auscultation, the same thing may be palpated with the palm. That is called friction parameters. It is caused by pleurisy for, it could be of different etiologies. So and then if the coarse crepitation is coarse enough, then we may even feel the crepitation on the chest wall. So these are the things which you can palpate. It should start with examining the most obvious abnormal area like swelling or pain, then obviously movement of the chest wall from front and the back, um, to see any asymmetry, then measure the chest expansion with a tape, then palpate the position of the trachea, the apex bit, and then three types of either fremitus or coarse crepitation. That's also a, I- it should be a crepitation fremitus maybe, but that term is not there in the book. So palpable coarse crepitations. So this is the palpation part is now over. So now comes the percussion. The percussion, how is it done? In case of chest, usually, except for direct percussion on the clavicle, the rest of the percussion is done by two fingers. As you know, the one finger lies on the chest wall closely. That is called the pleximeter finger, and the other one which we are hammering with the other hand, that is a percussing finger. So the percussions could have actually three sort of purpose for percussion. First is called a diagnostic percussion. So diagnostic percussion actually helps us to find out the when any abnormal percussion notes indicating the underlying pathophysiology, like a pneumothorax, like a consolidation, or like a pleural effusion and things like that, which is definite obviously abnormal from the normal resonant percussion notes. Then the second is, that's for the diagnosis. Second is the topographical percussion. The topographical percussion is done to delineate the border of a particular solid organ. Like if we do a percussion to find the upper border of the liver dullness, upper border of the splenic dullness, or we want to see the surface marking of the heart, the cardiac dullness. So those are the things is the topographical percussion. And the third one is the tidal percussion. So this is actually the, as you know, that with inspiration and expiration, the lung with inspiration inflates and it deflates in expiration. So the lung volume increases and decreases, and we can actually measure that by tidal percussion. That is usually done on the back, along the scapular line. So it is normally we mentioned that on the scapular line, the lower border of the lung is at the level of 10th costal cartilage, and that of the pleura at the 12th rib and 10th rib. And so usually if you percuss when the patient has completely sort of exhaled, and then ask them to take a deep breath and hold it and then percuss, then the lung will expand at least one intercostal space, one rib. So from 10th to 11th it will go. So that's the tidal percussion. So this is a type of percussion. So diagnostic percussion, topographical percussion, and tidal percussion. Now start percussion by percussing directly over the most. This is the starting of percussion. Most prominent part of the clavicle without using the pleximeter finger. You just don't need the pleximeter finger. You just directly percuss with your right hand, maybe left hand if you are left-handy. So on the that is the, we are seeing the apical area of the lung, and then percuss along the mid clavicular line, along the mid axillary line, and then along the scapular line in the back. From the in the front it starts with the supraclavicular fossa, and then the upper up to the upper border of the liver dullness in the right side, and in the left side up to the cardiac dullness first, and then leave the cardiac dullness, then go down, and you may find the splenic dullness and stop there. Then percuss along the mid axillary line from axilla to the 8th intercostal space, and in the back from the suprascapular area, the over the interscapular area in a batwing fashion up to the 10th intercostal space. Then two or three two important areas are there. One called the trob space. This is an area in the front. It represents the position of the fundus. There's a fundus of the stomach. Fundus of the stomach is just left cordial area, um, a left subcostal area type area. This is on the right hand side is the left lobe of the liver, and the left is the spleen. So between the spleen and the liver, so this is the area where the gastric fundus of the stomach lies, which is usually tympanitic. But if there is any problem with with a mass in the gastric fundus or splenomegaly or enlargement of the left lobe of the liver, then this dullness, there will be dullness in the trough space. Then the percussion of Carnegies isthmus. This is an area which represents the apex of the lung. It's on the top of the shoulder here area, and in the medially it's the nape of the neck, and laterally is the shoulder joint. So in between a triangular space on the top, which represents the apex of the lung. If it usually resonant, but if it is dull, then may indicate a maybe an apical tumor or tubercular consolidation, or maybe another other consolidation, or maybe thickened pleura or something like that. So the chronic isthmus and drop space, these are the two special areas. The character of percussion, how does it how is it, what is normal percussion? And normal percussion of lung is resonant. It's the resonant percussion. If it is more than that, it is hyper resonant, what happens in emphysema. And then tympanitic means like drum, beating a drum. It happens when there is a pneumothorax or large emphysematous bulla, or large cavity under the skin. It's sort of superficial in the lung. And then resonant, scodic resonance is another term used when there is a the feeling is like you are percussing on a wooden box. That can happen with pleural thickening, and maybe in pulmonary TB. Then impaired resonance happens. Then dullness and stony dullness. The stony dullness is typical of pleural effusion, and then others like consolidation underlying it may be dull, and if there is a sort of thickened pleura, then there may be impaired resonance and so on. So this is the character of percussion notes. And then comes the auscultation. So auscultation part, things to be noted during auscultations are three things. We are looking for the breath sounds, whether it's normal or abnormal, or characteristics of it. In the vocal resonance we are listening to, and then any adventitious or added sounds. So breath sounds, there are two types of breath sounds we normally hear. One is the normal vesicular breath sounds, which is the classically heard in the inframammary, infraaxillary, and infrascapular area. That's the area which the classical vesicular breath sounds are found. The vesicular breath sounds are created by entry and exit of air from the alveoli. So the when the alveoli are collapsed and the first time air is entering into the alveoli, then there is a this opening up of the alveoli. It's like a the dry leaves, when there is a wind, it causes a sound. It's like that. So the vesicular sound. So the characteristics are, it's a rustling type, as I said, the dry leaves moving. So rustling type sound. There is a long sort of inspiration part, and then when you are listening with your stethoscope over the alveoli in the chest wall, so the air is entering towards you and going there, so you will find very clearly the inspiratory sound. But when there is expiration, the air is actually going away from your stethoscope, and it's also going from the smaller airways to the larger airways, so the sound fades away very quickly. So the only the initial part of the expiration you can hear, not the latter part of it. So inspiration and part of expiration you can hear in case of vesicular sound, and it is rustling in nature. Bronchial breathing, typically it is heard over the trachea, infrascapular area, infraclavicular area, and also in the interscapular area, where we know the division of the main two bronchus. Um, how is it? Now, it's a high pitched, harsh sound and blowing type character because it's going through the windpipe. It's a blowing type, and here you can almost equally hear the inspiration and the expiration part of it. But when you are listening to the inspiration part, the air enters from there, goes down, 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 and then when expiration is coming back, so there is usually a small gap between the inspiration and expiration. It is harsh in or blowing in nature, and you can hear the expiratory part much more longer or almost nearly equal to inspiration part. And then the bronchovesicular sounds, this can be in some areas of the lung. This can be like a infraclavicular area and interscapular area. You may normally hear a mixture of bronchovesicular sounds where or if the person is very lean and thin, when you are listening to their chest, this breathing may be a mixture of bronchovesicular. So that's the normal breath sounds we are talking about. Now coming to the adventitious or added sounds, what are those? Um, First thing is the dry added sounds. So this is called ronchi. So this is caused by flowing in the sort of air moving through a narrow windpipe, like what happens in bronchial asthma, in sort of COPD, sort of thing, bronchospasm happens, or there is a swelling of the bronchial lining as happens in chronic bronchitis, or spasm in bronchial asthma. So there's the narrowing of the airway, and when the air is um, when it's entering or going through that, there is a dry sound called ronchi, and moist sound is called crepitations when there is a presence of exudates or fluid inside the alveoli or the respiratory tract, and air is sort of moving through that, then we will find a moist sound or crepitations. It can be fine crepitation, it may be coarse crepitation. The fine crepitations are usually heard when there is a little bit of fluid or exudate inside the alveoli. So when these moist walls they are sticking together and the air is entering into that, so they are opening up. This moist walls of alveoli are separating, and this gives rise to a fine sort of moist sound, which is classically found in early left ventricular failure. It may be in the fibrosing alveolitis or very early stage of developing pneumonia. These are the things where you can find these fine crepitations there. And you will find it very late in inspiration, when this is opening up of the alveoli. And the coarse crepitations, which is very coarse, means it's much more um, uh, coarse in nature, and this is found in case of resolution phase of pneumonia. In the resoluting, lots of exudates are there in the respiratory tract, and usually in the bronchioles and things, and then it causes sounds. Pleural rub, when there is inflammation of the visceral and parietal pleura, then when the and there is rubbing between the two inflamed pleura, which gives rise to a rubbing sound or the pleural rubs. Then there is called as succussion splash. It happens when there is a hydropneumothorax type thing. I mean, there may be a pneumothorax or sort of pleural effusion. Subsequently, they developed a pneumothorax. So we call hydropneumothorax, or if there is sort of surgery to the chest containing fluid. In if you the patient means second is succussion splash, that is the water moving inside sort of close short of that's the tradition rub and some vocal resonance. The vocal is the auditory part of vocal premises. So that means when somebody is talking, means producing sound to the vocal cord, that is transmitted through the respiratory tract into the chest wall, and we can listen, we can feel with the palm, that is the vocal premises. We can listen with the stethoscope, and that is the vocal resonance. It could be normal, and normal means that uh, we can hear that noise, like you were saying 99, 99, 99, and you will feel that the sound is coming from the your bell of the stethoscope. The sound is coming from there. But when this intensity increases, the vocal resonance, it is called bronchophony. In that case, this more sort of intense sound, it is coming from your earpiece of the stethoscope. It sounds like that. And if it is severe enough, then it may be, you may be listening every syllable of the sound very clearly, which is called whispering pectorally, like somebody is whispering into your ear directly, syllable by syllable. Then in a particular case, this increased set of vocal resonance can be heard like a bleating sound, and usually found above an area of pleural effusion. They usually find this bleating noise called egophony. And then the pneumothorax click. Pneumothorax click means if there is a considerable amount of sort of tension pneumothorax, then if you are putting the here the heartbeat, with every heartbeat, you will hear a clicking sound over the pneumothorax. We call it pneumothorax click. And again with pneumothorax, large pneumothorax, if you put a coin on the back of the chest and strike with another coin, this is called coin sound or bell sound, which is very accentuated sound. You'll be able to hear from the front chest wall as a coin sound. And pericardial rub, we talked about pleural rub as an adventitious sound. and in the vocal resonance here, pericardial, because even if you stop breathing, hold your breath, if there is inflammation of the pericardium, so if the pericardial rub, you may hear as well. So that. So this is the auscultatory thing. So basically, normal breath sounds, the vesicular sounds, the bronchial breath sounds, and bronchovesicular sounds. You must know the detailed characteristics of these sounds. Then the adventitious sounds like dry sounds or bronchi, commonest cause is chronic bronchitis, bronchial asthma, this sort of thing. So okay, can you hear me? Yeah. Hello. Hello. Hello.
Yes, the
Can you hear
aspirants are
me?
here.
All of them are there. None, no one is saying hello, Sana.
Yes, sir.
Yes, sir. Okay, I'm audible. And next coming the
So the
cases.
PPT is gone.
Um,
Actually, sir, the network issue is there is being a network issue, internet.
oh,
Yeah, and
so
the PPT is
from
not
where
visible.
should I have to discuss the previous one?
Yes, sir. The PPT is not visible.
Hello.
The PPT is not visible, sir.
Okay. Now,
No,
all
sir.
right.
So try
Okay, just
sharing
a
it
minute.
again.
Just a second. Yeah, from up to what actually they could see. Uh, just a minute. Screen share. Hello. Can you see now?
No, sir. So I think there
Hello.
is. I think there is internet issue. Yes, sir. The screen is visible.
Hello.
Share the
Yeah.
PPT.
Now like auscultation, percussion. So those are the things coming or not.
So
You
the
can see
PPT is
this.
not visible. So actually, there is internet issue.
But my
A
internet is
slow
showing that it's
network.
fully available here. Uh-huh. Okay. But you can listen to me what I'm saying.
Yes, sir. But sir, your voice is
Hello.
breaking. Sir, because of the network, your voice is breaking. Actually.
Is it just happening or the throughout it was like that?
No,
Oh,
sir.
don't
It is
know. I don't
happening
want that.
from like past 5 minutes. So the PPT is now visible, but you're not audible and your screen is getting stuck.
Oh, God. I don't know. Just a minute. I think I'm not
Uh,
mute. It's
so
showing
your voice is
it's
breaking.
I'm okay. Uh, Video is also on. So it's uh, so whether our candidates are online still, just check that. Hello.
Yes, sir. It's fine, but yours.
Okay, how far they could listen to me? Just ask. Hello.
Sir, we listen till pericardial rub,
Hello.
pleural rub.
Oh, pericardial auscultation. Oh, you could hear till that actually. So it was the whole. Okay, now actually, oh yes, auscultation part. Auscultation part is over. With just breath sounds, adventitious sound, that is rhonchi, crepitations, pleural rap, sarcasm splash, and then vocal resonance, normal bronchophony, whispering, pectoral decay, egophony, pneumothorax click, well sounds, and pericardial rap. So now we are coming to the actual. Hello. Hello.
Sir,
Your
I think it is
internet
getting
is
very
too.
difficult because of the network issue. Are all the aspirants having the same issue with the network?
Yes.
Sir, I think it will be really impossible to continue the class this way. So, shall we like conduct it after 2 days, starting from here only?
No, actually, the thing is, my part is already almost over. Actually, just one slide. We're just talking about what sort of case comes in the exam. Okay, so just last slide. Actually, I am with dealing with the last slide now.
Okay, sir.
And
Okay, sir. Okay, sir. Yes, sir,
interactive.
your
It,
voice
it
is
would have been an
breaking very.
interactive session.
Yes, sir. So you can continue.
Yeah, I don't know what to do. Okay, so if you can hear me, just say yes. Hello, hello.
Yes, sir. So you are audible. Are the
Yes.
Can you hear
can the
me?
aspirants hear?
Yes, we can hear.
Yes. Okay. Okay. And the screen. Can you see the PPT?
Yes, we can see the PPT.
You can.
Yes, sir, we can see.
Sana, you can see this.
Yes, sir. The screen
Yeah.
is visible.
Okay. Now, basically, yeah, basically it shows that what are the common cases given in the exams. So exams actually definitely the no unstable acute cases will be given in the exam. Usually not. So if somebody is having an active tuberculosis, somebody is having an active community acquired pneumonia and unstable, and the patient is having pneumothorax, this and or active TB, these sort of patients will not be given in the exams. Okay, usually not. Okay, and so usually relatively stable patients are given, and there is the endless list there. But the common cases which are given in the MRCP exams are COPD, that is chronic bronchitis emphysema case, then core pulmonal, then obesity, obstructive sleep apnea leading to peak weekend syndrome, so a cause of pulmonal. It could be the interstitial lung disease, that is fibrosis of different etiology, and fibrosing alveolitis. Again, the rheumatoid lungs, that's another cause of fibrotic lung disease. Then bronchiectasis and cystic fibrosis is one of the causes, and it usually affects the younger persons. So if somebody is having a bronchiectasis and pretty young, then you must think of cystic fibrosis as the underlying etiology. Then a pleural effusion of different etiology, superior vena-cava obstruction or syndrome, as we mentioned earlier, that prominent neck veins and chest veins, etc. Old pulmonary tuberculosis with fibrosis and leading to pulling towards the of the mediastinum to that side, and that is the old pulmonary TB. Then Cartagena syndrome is an uncommon, is a rare case, but if there they can give you. This is basically a case of bronchiectasis. This is, you all know that it's a sort of ciliary dysmotility disorder. So it affects the respiratory tract, leading to bronchiectasis. Similarly, there may be dysplasia of the sinuses. There is usually dextrocardia or situs inversus, and because of this motility, they have infertility as well. So those are the things, a component of cardiogenic syndrome. You will get the case as bronchiectasis. And obviously carcinoma of the bronchus, if the patient is stable, so they may come with shortness of breath, they may have associated pleural effusion and things like that. And rarely in the, not so rare, but in a normal chest may be given as an examination in the MRCP. Sometimes the patient may have had bronchial asthma exacerbation, PD exacerbation, and then everything has been settled. And at that point, when you are examining, the patient does not have any signs and symptoms of the disease for which they were admitted earlier. So that in that case, that may be a normal chest. So normal chest, if it is there, don't worry to tell this is a normal chest. If you don't find anything abnormal, this may happen. Um, and few points actually, if you it would have been very good actually if you could set up one-to-one discussion, interactive things. If I ask, so how will you sort of find a COPD case in your exam? So can you actually talk to me what you are expecting COPD case to tell you? So you have to take maybe in the short case sessions, you will say this patient is having this breath cough with, and now examine the chest. If there is any particular signs, actually they may ask you examine the front of the chest or examine the back of the chest, or may say okay examine the, if it is semi-long case they will say okay examine the respiratory system. So this is a COPD thing. And core pulmonale is what happens is it's advanced COPD leading to pulmonary hypertension and right heart failure that leads to sort of congestive cardiac type pictures. So they have the peripheral edema, they have got a bloated appearance, they may have central cyanosis, and have other stigmata of COPD. And similar things, you may see a very obese person who looks plethoric, central cyanosis, and with the failure with the peripheral edema. So it's called Pigwickian syndrome or obesity and COPD leading to cor pulmonale. So this cor pulmonale or the COPD, later on this bronchiectasis and cystic fibrosis cases, bronchial produce sputum. So examining the cases, look for any sputum pour around. Um, but while you are examining a case of interstitial lung disease, fibrosing alveolitis, or rheumatoid lung disease, they may have similar presentations like shortness of breath, progressive shortness of so ILD, fibrosing alveolitis, rheumatoid lung disease. So this is different clinically on the bedside. That is, they produce very little, and they may have more prominent cyanosis and clubbing. Pleural effusion, as you know, is depending on the degree of effusion. So there may be just basal dullness to hemithorax dullness. It may happen, and they may ask you any related to the cause and subsequent of pleural effusion. TB as a underlying cause, you mentioned on that as well. Capable of uh, by underlying malignancy. Usually, ये bronchogenic carcinoma of the lung, and the prominent features happen in the patient if it is suffering for some time. They are cachectic. That means lost a lot of weight. They have very prominent distended neck and chest veins which are not collapsing like JVP, not collapsing, they are fixed, and they may have venous engorgement under the tongue. Obviously, underlying cancer, you may have lymphadenopathy in the neck as well. So, and they will not have any sort of lower limb edema, usually not there, whereas they have facial and upper limb edema and puffiness. Old pulmonary TB, you may have a significant past history of that, and they may be short of breath, and you may find the signs and symptoms, usually cough and shortness of breath, but signs you may find the evidence of pulmonary fibrosis, like a decreased breath sounds, coarse crack crepitations, and things like that, or there may be pulling of the trachea to that side. Cartagena syndrome, as we already mentioned, carcinoma of the bronchus may present with pleural effusions or maybe a collapse of one lung. So depending on that, and sometimes rarely, if it is apical bronchogenic CA, it may have associated Horner syndrome as well. So those are the things you have to do. And as I mentioned, a normal chest as well may be your exam case. Hello, do you have any question? Hello, hello, can you hear me, Sana?
No, sir.
Hello.
So the aspirants doesn't have any question for now. If any question comes up, we'll be scheduling a session then.
Yeah, no, but actually, I think I am finishing my presentation now. Actually, it's the last slide. We discuss if they have any particular questions, we can discuss now, or they may ask me later on in mails and things like that.
Yes, sir.
Actually, Shana, is it not possible? Actually, like a Google Meet, we can see the candidates who are actually there on the other side. A little bit of face-to-face sort of. It's not possible in this platform. Hello.
Well, sir, only one aspirant is here for now. Everyone just left the session now, but we could do the
Yeah.
face to face in year 2, sir.
Yeah, no, that's fine actually for today. So who is there on the other side? Tanmoy.
Yes, sir. So, sir, shall we conclude?
Yes, that's fine from my
Yeah.
side. How was it, Fatma?
Yes, sir.
How was it?
Sir, it was actually a very nice session. It was very nicely covered. All the
Hmm.
student, there were 6 students with us. They
Hmm.
were all here in this session.
Okay, okay. No,
Thank
that's
you, sir.
fine. Yeah, uh, this platform we are definitely using, but like in the classroom, it happens a little bit different.
Yes.
But
And so the
no,
offline MRCP was
yeah,
also
that's
great
fine. I
last
think
time we
if they
had.
benefited with it, that's
So we'll be
absolutely
seeing you
fine.
this time too, I guess. So I believe we'll be seeing this time too in November, the offline MRCP PACES in the
Yeah,
October.
that's the October, na 23rd
Yes,
or
sir.
something October. Yeah, yeah, yeah. That's fine.
Yeah. Thank you, sir.
Okay. We are concluding the session then, Padma. Okay.
Yes, sir. Thank you.
Thank you very much.